as a medical doctor, and at the same time, I now did MPH. So I'm really able to see the length and breadth of not just someone being sick, but facts, and also the role that socioeconomic status, ethnicity, and everything plays in cardiovascular disease. So, Bio reached out to me, just giving information on prevalence of cardiovascular disease and what it is that we can do, to limit the risk. As you know, we can try to prevent it, but at the same time, some things are just going to happen. So how do we just limit the risk? Or even when a couple of things happen, what are the things that you should have invested in, in yourself to be able to bounce back to full function, a couple of things like that. So I'm going to share my screen. Give me a moment. So can you guys see this screen?
Yes.
Yeah. Yes, we can.
Okay, all right. Okay, how about now? Because I have a full screen now. Can you?
Yes, we can still see.
Good.
Yes.
All right, so it's prevalence of cardiovascular disease in young blacks. And again, just some basic facts that I've known for a while, and also I was able to look up. Over the years, definitely with the advent of medications coming on board, new informations that people are getting more aware of their situations and stuff like that. The population base, there's been like a reduction over time in cardiovascular disease incidence and also the death rate, But in the Black folks, while everything is still reducing, it's not the same as it's reducing compared to other ethnicity, especially when you compare this to whites. And this burden of this cardiovascular disease, especially in Blacks, we actually, can see it vividly during this COVID period. Heard news that Blacks are dying at an even higher rate of COVID than other ethnicities, and it's because of their underlying medical conditions, with cardiovascular disease playing a very big role in that. So this really remains one of the primary causes of disparity and also reduction in life expectancy, Blacks versus whites. And again, most of the data I have, actually, I would say the term that we used was African Americans. But again, I'm just trying to use Blacks because some of the data might not really, translate to Blacks, for example. There are some things that probably will be here in the United States that we don't have as much in Nigeria. But again, just bear with me, I probably will be using Blacks more. So for example, these are the death rate, as I was saying, when it comes to cardiovascular diseases, when you look at the rate. So you see that over the years, actually, we've been doing better according to the rate. It's still pretty high. For every 100,000 persons in Black folks, you have about 208 deaths, of cardiovascular disease-related deaths. And compared to others, we're still doing very worse. So it's coming down, but at the same time, there's still significant disparities when it comes to other ethnicities. And when we say cardiovascular diseases, right, it's just not one thing. It's a lot of things coming together to form that term. Okay, it's something we call coronary heart disease. Coronary heart disease is pretty much what I do. It's when, the blood supply to the heart develops plaques, and subsequently this kind of narrows down and it causes of it causes an heart attack. So, when this happens, come to the hospital, there are two forms. There is a major one that you have to go to the hospital immediately. We have to open that and put a stent within 30 minutes. And then there is one in which the blockage is not acute. You know, it just gradually it worsens over time, so that when you walk in, maybe you've only walked, before you can walk a mile without problem, but now you walk just a quarter of it, you're having pressure in the chest, you breathing heavier than you should breathe. So this might be due to narrowing of the artery supplying your heart, so the heart is not getting the blood supply. So that's coronary heart disease. Another thing is the sudden cardiac arrest. Sudden cardiac arrest is the heart just stopping suddenly. You know, these are people that you have to resuscitate, perform CPR on. Heart failure is really, really, really big. It's one of the main killers of the Black folks, especially everywhere, also in this country. Strokes or mini strokes, the mini strokes, we call them TIA, the transient ischemic attack, and also peripheral artery disease. Peripheral artery disease is, and these are when you have that same narrowing that happens in the heart is happening in the other arteries in the peripherals. For example, maybe when you walk, you know, when you walk and you feel pain in the calf, you feel pain in the leg, it gets better with resting. You know, this is called peripheral artery disease. This might not lead to direct death and stuff like that, but people with peripheral artery disease are also associated with significant coronary artery disease, cardiovascular artery disease, because the narrowing of the arteries in the legs is the same artery that is in the heart, is the same artery that goes to your brain that causes stroke. Okay, so all this encompasses what we call cardiovascular diseases, and it's really is a major killer. So I deal with cardiovascular diseases, but when I talk to my patients, I always tell them, when I'm getting involved, it's probably maybe a little too late. Because when I'm getting involved, I'm just palliating, right? So the artery is already blocked, I'm opening it up, okay? The heart is already failing. I'm giving you medications to see if I can improve it, or maybe support it with mechanical intervention. So there are a couple of things that we need to have been aware of early in the years that should have been taken care of before it actually led to all these cardiovascular diseases, okay? And this is what we call risk factors. And the risk factors are really always the very scary things. So the risk factor, the traditional risk factors are these, okay? Hypertension. Hypertension is one of the biggest things. Diabetes mellitus, all right? Elevated cholesterol level, obesity, sleep apnea, and other things, especially in the Black community. We're talking about our kind of diets that we grew up with and that we know to eating. Smoking, okay? Reduction in physical exercise. You know, we don't do physical exercise as we should do, okay? So these are traditional risk factors that over years, that if we've known, and even at especially this age group, that we got an handle on, we can reduce the potential risk of the cardiovascular disease that is coming down the road, okay? And again, even to Black folks, the unfortunate thing is now, despite the fact that we're having medications to actually treat these things, even the effectiveness, especially again in African American folks, is even questionable. Because of so many things. And again, we'll discuss that socioeconomic factors are also part of the factors that are actually leading to this. So let's look at let's go back to cardiovascular disease, look at the prevalence, and then we quickly also go over the traditional risk factors. So the coronary artery disease that I said, this is regard study. Regard study is one of the studies that we usually that we follow in cardiology. And if you could see that the total coronary heart disease, which is narrowing of the arteries to the heart, causing, you know, heart attack and stuff, which is a major killer, it's a little more in the Black population than the white population. I'll bet a little more. And even in another study called the ARIC study, that difference is even not really statistically significant. So, yeah, numerically, maybe we have more risk of getting this than the white people. But when you look at the fatal coronary artery disease, those that are actually dying from it, it is statistically significant between Blacks and white folks. Okay, And if you look at those that have it and they are not really dying from it, you know, as much, fine, people still die, but they are not dying as much. Non-fatal ones, white people still do better than their black counterpart. And the same also goes for women, okay? So, and over the years, the regard study is a study that actually we've been following over, is a population study that we've been following over 20 years, and they analyze it every year to see how people are doing. So as I showed earlier, the decline in this coronary artery incidence, you know, is declining in both blacks and whites, but even it's declining even much more in other ethnicity than blacks. For example, in the last decade, it's declined more than 6.5% per year in whites compared to just 3.2 in blacks. So finally, we're getting more awareness out there. We're trying to do more of reduction of these diseases. Both, again, it's not as good as the other ethnicities are doing. I have a heart failure. So heart failure, to me, I think is really one of the most debilitating things that start happening once people are reaching their age 50s and age 60s. So, and it's important if you look at this slide that I'm showing. So overall, this is kind of old data, but it's still the same. So overall, you see the prevalence of heart failure. So it's an age thing. So it worsens with age, right? So in the age 20 to 39, which is roughly where we are, it's really almost 0 to 0.3. It shouldn't be happening at all. And we do know, again, that even for all the ages, the prevalence is even still more in blacks versus whites. So when they were looking at these a couple of years ago, the cardiac study, because they saw these differences in blacks versus on whites. So in around, I think this was around maybe probably maybe the 1980s. These studies, what they did was they started enrolling people between age 18 and age 30 years old, and they started following them every year. So these are pretty much people that were healthy, right? So they were healthy. So they enrolled about 5,100 and something people in this study. And in 20 years, you know, these are young folks they were enrolled from 18. So most of them, and they were enrolled at age 30. So they're now still less than 50, right? So when they did this, they are still less than 50-year-old. So of the 5,000 in this age group that shouldn't even have anything, about 27 patients actually developed heart failure before they reached age 50. But the analysis is interesting. If you look at those that developed heart failure, black women and black men, okay, 26 of the 27 patients that they were following right from young were black people. The white people, they fared better. So the white guys tend to have development of heart failure towards elderly years, but for black folks, it starts earlier. It starts around the age group that we are right now, as you can see, as I'm pointing out in this study. But among all these patients, all these 26 guys that develop heart failure, what is the leading statements there? The leading statement, as you can see, all of them is people with hypertension. Okay, over the years, you can see that the majority of them developed hypertension. Hypertension was really the main focus. So how will hypertension cause heart failure? Number one, black folks have a genetic tendency to have what we call a source-avid hypertension, which is a little different from how whites get their high blood pressure. The high blood pressure by whites are really due to arterial stiffening. So blacks have a combination of both: arterial stiffening, in which your arteries, you know, the way as you get older, they stiffen. And also, we also retain a lot of water and salt. So what happens is when there's a big pressure, that your heart needs to pump against, initially the heart compensates for it. It's like you go to the gym, right? You're pumping, you're gonna get muscles. So the heart compensates for it, the heart muscle thickens. So as it's thickening, it's getting more muscles to push out against that pressure. But with time, the heart is gonna burn out, okay? Because the pressure becomes too much for it, and then it starts failing. So hypertension is really a very big deal when it comes to this. Let's also look at another risk factors. What is another risk factor? Another cardiovascular disease apart from heart failure is cardiac arrest. Cardiac arrest, the major cause of cardiac arrest, again, is also when you have blockages in your arteries and your heart, and there's suddenly an acute closure, the heart stops receiving blood supply, then it stops. When they go to the hospital, even when they go to the hospital and you are lucky to actually be resuscitated and you survive this. How about the survivor out of the hospital? You could see that Black survivor, as you can see here, where's my mouse? So as you can see here, this is the survivor to discharge. The survivor has been getting better over the years, but again, the survivor is not as good as whites, okay? Which I think we can do better. And again, this other one was a recent data from 2018, just 2 years ago. And this was from the medical claims that was linked to death data. After your arrest, the survivor probability, the probability that you're going to survive, you see, is much lower in Black people compared to white folks, even some years out. So so cardiovascular disease is a big killer. And again, in every data, in every measurements, the Black folks tends to do worse. And the study I presented earlier, you could see even Black folks as young as less than 50 have this risk. So what the traditional risk factors, if you look at these data from the National Health and Nutritional Health Survey, this is the total. Total here is the non-Hispanic Blacks. You could see that about 40% in Blacks, are much more worse than all other groups, much worse than white folks, much worse than Asians, and much worse than Hispanics, even men and women. So this is this is for hypertension. You see, it's worse in Black folks, hence the risk of cardiovascular disease. And even if you look at diabetes mellitus, these in non-Hispanic Blacks, you could see it's a little higher compared to or even in the total group. So these risk factors are kind of more bound to happen more in African or maybe Blacks or African Americans. Again, look at obesity across all the spectrum. Obesity is even much more in Black folks. This is in extreme obesity in children. This is among adults, that are greater than 20. You can, and with a BMI is the way we measure obesity. You see that African Americans are even much bigger, weight-wise than other ethnicity. And when it does come to extreme obesity and severe obesity with BMI greater than 40, we are like double that of other ethnicities. So all this actually causes the risks. Again, physical inactivity. Physical inactivity is multifactorial. When you have a socioeconomic status, you have to work 2 jobs, which, people in the Black communities probably are doing. When you get home, you just really want to rest so that you can start the next day with some energy. So, and again, you can't go on vacation like when you want to go to, because you're working for somebody, you don't have your job. You can't just say you want to take off. So those are part of the things like, again, Black folks, for example, they live in a community that most of them don't even have maybe a park that they can walk, a park that they can exercise in. All those things leads to physical inactivity. And again, I'm also said poor quality and duration of sleep. Short sleep recently has also been linked to cardiovascular disease. If you're not sleeping enough, who are those likely to not sleep enough? Again, these are more, they tend to also be the black folks. So these are really the risk factors, as you can see them, that are predisposing us to high risk of cardiovascular disease over the years, because this is an accumulative thing. So now, how can we prevent this? How can we do our part to prevent this? Is awareness. And this is like what we are doing right now. Awareness is for you to know that you are in a group that has a higher risk of having cardiovascular disease because of your tendencies to have other traditional risk factors. That's number one. Awareness is the key. And awareness has really been the thing that is improving the trend over the years, because now people know, oh, okay, maybe I'm at risk of getting high blood pressure. Maybe I'm already 40. Maybe I should go for a regular checkup, to see what it is that I'm at risk of. So according to the United States Preventive Task Force, especially maybe for high blood pressure, it's recommended that once you get into age 40, you start having an annual screening of your blood pressure. Okay, I think the one thing that we can really do to reverse and significantly reverse the risk of cardiovascular disease in Black folks is management of blood pressure. Okay, if that really can be under control, I think a lot of things will actually be better managed. So screening of blood pressure at age 40, and for me, I think even before age 40, for Black folks, I probably would say maybe even age 35 would be the best age for you to, at least, even if you don't want to go to a doctor, we have a lot of pharmacy centers, all these shopping centers that have blood pressure machines, which I think should be calibrated. And all you have to do is just go do your blood pressure. I have an idea what the blood pressure is. I don't want to go into so many medical talks, but the number that you're looking for, that you should know, like, okay, maybe you're at risk, the number you're looking for is 130. The upper number should be 130 or less, and the lower number should be 80 or less. Okay, those are the numbers. Anything above that, that's like probably you might be at risk for high blood pressure. So, and it's even recommended that blood pressure is done more often in people that are at risk. And who are those that are at risk? I just said people that have blood pressure that are greater than 130 over 80, people that are overweight or obese. And I'm sorry to say not to ding everybody, but I think probably every one of us is overweight. We might not be obese, but every one of us is overweight, okay? And the way you can quickly do that is measure your weight, measure your height, and you just go on Google, look like BMI, okay? BMI calculator. Put in your weight, put in your height, it's gonna tell you what your BMI is. If your BMI is greater than 25, you are overweight. If it's greater than 30, you are obese, okay? And again, look at the high risk groups. High risk means African Americans. So African Americans are actually classified as high risk. Just for you being Black, you're high risk. So getting your blood pressure there, especially once you hit age 35, it's good. And now we actually come in terms again that blood pressure management might be different even in Black folks. Before, we have different medications that we'll be using. But as I said earlier, the mechanism of blood pressure is a little different, okay? Arterial stiffening over time, over age, is why more people get more blood pressures when they getting older. But in Black folks, again, we call it salt avid states. You know, we tend to retain more water. We tend to retain more salt. So now emphasis on something we call maybe hydrochlorothiazide or clothalidone. These are medications that should be first line in the management of blood pressure, especially in Black folks, okay? Things that we used to do before in Black folks, for example, medications like lisinopril or losartan, they are still good medications, but those, especially for Blacks, are kind of dialed down because they know the mechanism of hypertension is a little different. So again, all these will be things that you will talk to your doctor if they think this is a way to go. So that's number one for high blood pressure. Number two is diabetes, okay? Diabetes, we are at risk for diabetes because, again, number one, physical activity, we don't do as much. Number two, our diets are really high in carbohydrates. A dietitian, but again, I've always seen them talk to my patients, and I kind of have some idea that we'll go through later. But foods in high carbohydrates also predisposes people to diabetes. But the good news is it takes a while to actually really develop the full-blown diabetes, okay? There's something we call pre-diabetes that usually occurs first. And that is what we always want to catch first. So I will advise, like 35 years old and above, you get something called the blood screening test to see maybe you're at risk. Because when someone has a pre-diabetes state, just from lifestyle modification, exercise, eating right, you can actually reverse that risk of diabetes, okay? You can reverse it, meaning you can go back to normal instead of, but if nothing is done, the rate of becoming diabetic is exponential, okay? And that's why it's good to do this screening. And diabetes is the killer of all. It's everything. From diabetes, you get heart attacks, you get strokes, you get renal damage, you get everything, okay? So that's very important. Another thing is screening for cholesterol. Cholesterol, in Black folks and white folks is about the same rate. And the US Preventive Task Force really does not lay heavily on screening of cholesterol. But once you go to a doctor that you want to do your regular physical, and around this age, cholesterol is one of the things that they're gonna test for. And this is important because those plaques that are laying down, those blockages of the arteries, those blockages of the arteries to the heart, arteries to the brain that's causing the stroke, arteries to the leg that is causing peripheral artery disease, are all built of cholesterol. The body needs cholesterol. All your skin, all your cells are all made of cholesterol. So the body gets cholesterol normally. So you're going to have some cholesterol. The liver produces cholesterol. But from diet, sometimes you can get a lot of cholesterol. So cutting down on your fatty foods and stuff, which I'll go over later, can actually reduce, the cholesterol levels. And there are some people that, regardless of what you eat, you just have high cholesterol because the body produces it. Those people, reversing it with maybe exercise. Some you just have to take what we call statin medications to reduce your LDLs levels. And that's why I think screening is better. So these three big things, I think, are what should be controlled earlier to prevent the development of cardiovascular disease. Okay, and I think we are really at the right age for this. Physical activity, we come back again to physical activities. These are the recommended. I know sometimes it's tough to do this, but these are the recommended things. And anything is better than nothing, okay? You don't have to okay, this is going to be the target, everything. Anything is better than nothing. So 150 minutes per week of moderate intensity exercise. So what does moderate intensity exercise means? If you're able to run, that's fine, but you don't have to run. All you have to do is walk fast. Walking fast, to the point that when you walk, you sweat it out, actually classifies as moderate intensity exercise, okay? So because we have a couple of us, maybe, you even thinking of maybe you want to go running and stuff, that probably discourages you. But taking a walk, not leisure walk, but walking fast, making sure that you break up in sweat when you do that actually should qualify you. So 150 minutes per week means about 30 minutes a day, averagely. Or if you are the type that can, get on the treadmill, run fast, do everything, you just need about half of that. 75 minutes of vigorous exercise, of aerobic exercise is also good. And in addition to these, muscle training, a little bit of muscle training, curls, press up, weights and stuff like that that you can do might also help with the physical activity. And this goes a long way. If every studies have shown people with physical activity, it comes out every year, how do you do better when it comes to cardiovascular diseases? Again, diet. Unfortunately, our food are kind of very, very rich in carbohydrates, in fats. We tend to eat rice a lot. We tend to eat pounded yam. We tend to eat amala. We tend to eat eba. All these things are, these are good food. These are good food. Yam. But they are very high in carbohydrate. They also have their own share of trans fats. So the number one about food is portion. Okay, we can, our fathers and forefathers have been eating this thing. They're doing okay, but to improve, because they don't have the access to the ice creams and the cookies that we were having, so probably they lived a longer life. But here, every time you walk into the lounge, right? Once you eat, there's always a cookie. There's always an ice cream, and you take that every day. Okay, it's one of the killers. This number one thing is portion. Okay, reducing the size of the plate really limits the calories. Okay, we're not even talking about the components now. Limiting the calories, that's number one. Number two is let's engage in fruits and vegetables. Fruits and vegetables, surprisingly, with good lifestyle modifications, they go a very long way. Okay, and any fruit should be okay. Apple, bananas, and orange. This is something that I think we can get on. How do this come about? The fruits, they have antioxidants. Okay, they have antioxidants. What happens is when you build up cholesterol in your arteries, all the white cells in the body, the macrophages, they go, normally they are soldiers of the bodies. But at the same time in the cells, when they have these lipid droplets, they kind of phagot, it's called phagocytosis. You guys, you remember all these things that we did in secondary school. So it's called phagocytosis. They phagocyze these things. But when they phagocyze the fat cells, these fat cells become, they kind of become vacuoles, and they release all these radicals. Those radicals are what are the things that develops over time as plaques, and all these plaques will rupture with time. And when it ruptures, right, all those arteries, when it ruptures, it's not the rupture itself that causes an heart attack. It's like when you cut yourself, the body tries to stop the bleeding through something we call clotting mechanism. So when the arteries ruptures and all these things are exposed to the blood, the clotting mechanism starts. But because your artery is this way, it's maybe this tiny, and there's a plaque that ruptures, the body tries to, cover that plaque with thrombus. And what does the thrombus do? The thrombus just acutely occludes the vessel. Okay, so, and that is how strokes, that is how heart attacks, that is how all those things happen. So fruits are antioxidants that hopefully we counter the radical elements that are being reduced, that are being produced by the macrophages. Vegetables, the same thing. Whole grains are, low calorie diet. So, and low fat mix. Here we have 1%, 2%, 4% milk. I know the 2 and 1% milk don't taste good. They never taste good. The 4% milk it's good, but again, we should try to go for the low dairy products. Maybe the 1% milk, maybe the no fat milk. Poultry, chicken probably better than red meat. Okay, Again, I know we are used to red meat. This is what we are used to. Maybe just reduce the amount of red meat that you eat. Maybe that probably will go a long way. Using fish, legumes will be beans and other stuff. Those give you plant proteins. Okay. Oils. When you come to oils, I think there was a study that came out, I think last week, and now it's really confirmed. If you eat good amounts of olive oil, okay, substitute your oil for olive oil, it actually also has some preventive effects on cardiovascular disease. Okay, that's also very important. Nuts are very good, and limit sweets. Sugar sweetened and beverages, limit them. And another thing is the salt, low salt, and I'm hammering on salt because that is the #1 cause of high blood pressure. A tablespoon of salt is about 2 grams of salt. Normally, you should limit yourself to 2 grams of salt in a day, in the whole day. Okay, and that's about tablespoon. So probably everyone is doing a little more than what they should be doing when it comes to salt. If here we eat a lot of processed foods, the way you can look for salt is look at the can, look at any package, and look for the sodium. Okay, you will be surprised. Everything that is in this can has preservatives. What do we use to preserve their salts? So when you pick up a can of a soup, for example, what is in that salt is like 800 milligrams. Sometimes it's like 1,200 milligrams, okay? When you eat 2 of it, that's the whole salt you need in a day, but usually you eat more than that. So these are things that actually causes uncontrolled blood pressure. And again, what we call community investing through built environment. Although this is probably more than what we can do, but community investing are, the things such as, because there's always this say that when you go to Black community folks, the supermarkets don't carry fresh vegetables compared to when they carry what is being carried in maybe white neighborhoods, for example. The areas where the Black folks live, they don't have parks like where people can go running, in exercise, because people tend to stay more in cities than go through suburbs, stuff like that. So there are so much. I limited this because there's just so much that we can do in public health that can help reduce our risk factors like high blood pressure, diabetes, and cholesterol. That also reduces the risk of cardiovascular disease. So in a nutshell, again, I think we are kind of the lucky ones because we are still young, but now we are getting into the age where we are no more invisible. So every one of us should be seeing a primary care physician, measuring your blood pressure, having a baseline number for your cholesterol, what are your diabetes like, increasing your physical activities. At least, you're doing your part, when you do your part in these things, sometimes these things still happen. But again, how I'm always telling my patient, like, oh, I did everything. Why does this still happen? I will say, well, you came in with an heart attack. You were serious. We fixed everything. 2 days, you're already on your feet. That was because of the investments you've done. Okay, that's because you're active. That's because you're physically doing okay. If you're kind of sedentary to begin with, you're coming in with an heart attack, because you're sedentary, your body probably can't take it. You're intubated, you're stuff like that. It's not going to take you 2 days to get back on your feet. Okay, you probably will need to go to acute rehab when things are done to get back on your feet. So regardless of everything, so I think exercise, physical activity, and lifestyle modification is really the key. And when we get diagnosed with these things, don't let's fall into the trap of, oh, maybe I can do it by myself. Maybe I can use some traditional stuff to do it. There are proven medications that studies have done to show that this reduces your risk and it improves your longevity. Blood pressure, take the medications you have to be controlled. It's always good to get second opinion. Diabetes, cholesterol medications. And these, I think, they've really summed up things that we need to do to reduce those risks. Okay, so I think probably these are things that I have for you guys. If you have some questions, we can open the floor. I'll be happy to take them.
Thanks, Seun, for that, very eloquent, evidence-based, like we say it in medicine,
Thank you, sir.
So, I'm going to open it up. I think that was a question I saw in the forum while your presentation was ongoing, and it was from, Chief Ogumola asking, does dance count as exercise?
Dance counts as exercise? Yeah, it depends on the kind of dance. I think African dance probably can count as exercise, but nowadays, there are dance groups that they do so much physical dancing. Definitely that will count as exercise, because those guys, by the time you're doing already 20 minutes of that, you're sweating, So I think definitely that will count as some of exercise. I think what you should use to gauge this is, or what I use to gauge this is, if I'm doing something that makes you sweat, because for you to do a physical activity and you sweat, that is because you've exerted some, your body has required some metabolic needs that it met, okay? And when you do that, and at least for me, that's how I gauge it. When you sweat, I think you've expended some energy that actually goes a long way than not exerting yourself at all. So it depends on the kind of dance. Small dance, not getting your heart rate up probably won't cut it. But if you dance, good dance, all this samba dance and stuff like that you raise up your heart rate, is good. And if you physically exercising, the best way to know that you're reaching your heart rate target is your age minus your age from 220. So 220 minus your age, that's where your target is. So probably most of us, our target should be, your heart rate should be around 180 beats. So if you exercise, you want to make sure that your heart rate goes up to 180. That's like optimal, okay? Or probably more than that if you can get it up there, okay?
Thanks, Doc. Any other question for Akinseye?
Yes.
Go for your party.
Yeah, just thank you very much for the presentation. I mean, it's quite educative.
Should we pick somebody for 5 so that the person knows now to probably.
Sorry about that. Go for it.
Oh, okay. Yeah, thank you very much, Seun, for this wonderful discussion. Just quickly, in terms of tests, because I remember, I think the first set of slides that you talked about, you mentioned the importance of us having tests, at least around 40 years. What would you advise in terms of routine tests? Must it be like every month or biannually or annually kind of stuff?
Yeah, so yes, so for the things we follow are usually, the first thing is I would say from age 35 you first get your blood pressure checked. So because we are Blacks, we fall in the high risk group, so that's going to be every year annually. And it's annually only because the first blood pressure is normal, okay? If that blood pressure is abnormal, then your doctors will have you come back, initially they will start you on some lifestyle modifications, make sure maybe things are going with that medication. But if you go back to them in 3 months and the blood pressure is still high, then they will introduce the medications one after the other to see maybe they can bring it down. But if it is normal, I think as Blacks, you have to do it annually. For the diabetes, for sugar, I think at age 35, you should know what your baseline is, okay? And usually because we use something called A1C, if your A1C is normal at age 35, Usually, I don't think you have to, and you continue what you're doing. It's not like, oh, my A1C is normal, now I can, take Coke, ice cream, and stuff. Your A1C is normal, and you keep doing what you can do. Probably you don't have to check it again in the next 5 years, okay? But it's if the A1C is abnormal, if it's pre-diabetes, then it's according to what your doctors are recommending, and it also goes for cholesterol. Okay.
Yeah. So I asked this question because personally, I don't do all of this, but due to the enforcement from work, we get to do this every 2 years. So I get to know what's going on in terms of 2 years interval.
Yes.
Nevertheless, I've never had any cause to go back, but looking at what you're discussing with us right now, I'm beginning to think maybe there is a need to, personally, look into it, not just every 2 years, but more maybe every year or biannually sort of stuff to see what's going on. And now
Yes,
I get this because this is now another question, which at the moment I don't understand, but I need to go back to the doctor. The last one I did, which was last year, they go through all this cardiogram stuff that they
yes.
put on your, and the guy kept on reading the spikes that came out from the result.
Yes.
And for me, I don't understand what he's looking at. And he told me to go on the treadmill,
Okay.
that I need to do some exercise. Then I went back to measure again, and then he was still concerned. Then I was asking him questions. What's going on? Like, what are you reading? So he was telling me about a spike that I needed to know what is going on. So I don't have that, but in terms of this cardio analysis that they do when they have those spikes, is it a possible artery blockage, or what would you advise on that? I don't have exercise. I don't do consciously do any exercise apart from just normal walking, which is not up to what you have advised now. And I think I would consciously start doing that. But generally, what would you advise in terms of this cardio analysis, or just for checkup, for us to be on the right path?
Yeah. So when it comes to cardio, unfortunately, there is no screening method. There is no screening recommendation for anything cardio. Okay.
Yeah.
There's no screening recommendation at all. However, if, for example, if you go to a doctor for the first time, they probably will get an EKG, just as you said. So they get an EKG and the EKG is slightly abnormal. If you are kind of physically fit and can walk, the next thing will be they want to have you walk on the treadmill while you are connected to an EKG.
Yeah.
Yes. What does this? Because when you stress yourself, it's like a supply demand stuff. At rest, if you have narrowing in your arteries, blood will still flow because your metabolic demand is kind of at baseline. But if you exert yourself, your heart rate is faster, it needs more oxygen, it needs more food. Because of the narrowing, the heart is not going to get enough blood supply to maintain that metabolic standard. So that's probably you get chest pain. For those that will not get chest pain, what we call ischemic cascade is you probably will see something on the EKG before you get chest pain. Okay, so probably that's, and what that does, again, you got it right, is it usually probably will suggest maybe there's a blockage in the arteries of the heart. Okay, so that's the first thing. So usually there's no recommendation for any heart screening. But number one is when you go to a doctor, they probably will do an EKG. Number two is for high blood pressure. When you go to get an high blood pressure, if your blood pressure is high, it's always the next thing to do to make sure we rule out something we call hypertensive heart disease. Okay, we do an EKG, they will do an echocardiogram of your heart. Okay, to rule out hypertensive. So it comes with that territory. Okay, so I think back to your question, if you did the stress test and they gave you clean bill of health, I think probably that's okay, because sometimes the way you place the EKG might kind of give you different results. a stress test will give them a better objective information. And if you're able to do your stress test, no chest pain and no EKG changes, and they give you a clean bill of health, at least 68 to 70% of the time, that should be right.
Okay. Thank you.
Thanks. I think Leke was trying to chime in.
Yeah, I think so. I think I was. Can you guys hear me?
Yes, sir.
Yes.
Yes. So I just have a quick question. You had mentioned earlier about hydrochlorothiazide. That are you saying it's suggestive evidence that it helps more in African Americans than compared to like other drug class?
Yeah. So yeah, so we have some first-line drugs now that the recommendation is to have some first-line medications, because we have a variety of medications that we use for blood pressure. Both, especially in Black folks, if black folks comes to me, or maybe a doctor is saying this blood pressure is not controlled, and I look at them, they don't have hydrochlorothiazide or the other form of medication called clothalidone. Probably even I prefer called clothalidone than hydrochlorothiazide. Then you've not really helped that Black guy, because this is something that I believe really works, because we have the mechanism is a little different. Okay, so I just throw it out there. The first line medications are what we call amlodipine. I'm not sure, maybe you guys are aware of this. It's called amlodipine, called Novask. Then hydrochlorothiazide or clothalidone. Okay, that's another medication. And then the family of the ACE, which is called lisinopril or losartan. I usually will start the first two, if needed, before going to lisinopril or losartan. But if it's diabetic, maybe I might consider the lisinopril or losartan earlier than what. So yes, I think I'm not saying that hydrochlorothiazide or clothalidone is better than the rest, but for Black folks, I think it should be added. You know?
Tracking.
Okay.
Any follow-up, Leke, before I go to Oluyeye?
No. It pretty much just it is. Because I just want to know, at least for practice as well. But one thing I was just going to mention is, like everybody will say, so people don't have that ability to exercise or to do things physically. But I will also reemphasize the cooking of our wife. You know, I'm just trying to make a statement here. I'm physically active. Pretty much everything that Dr. Akinseye mentioned, if I go down the list, I pretty much do at least about 89% of it. But myself, my blood pressure is still not go. And so there's this force between myself and my wife that, okay, you need to reduce the salt. And so as we get to that age, thank God, we are pretty much still, at least, we are less at risk right now, because from the presentation, we're pretty much 0%. We talk about the heart failure, the heart attack, the stroke. So it's just something that we encourage, everyone. If your spouse is cooking for you, it's something we have to reinforce, because the salt in our Nigerian food really has to everything. You know, while we're on the meeting, my wife called me and I told her, "Oh, I'm on the crash school, the Zoom thing I told you about." And jokingly, I was telling her that, "Hey, remember the corn you cooked last night? It was very salty." And she said, "No." So we might want to drill that to our spouse or wife. If they are the one doing the cooking, it's the best education to let them know that we are reaching that age as men. From the graph, if you look at it, it's more men have more all of this CVD than women. But the woman does the cooking. So I want to maybe just want to chip that in to encourage our wife, if the best they could do to reduce the salt in our African food. Maybe that would be
and again, even to say that once you have high blood pressure, diabetes that is not controlled, and you're having cardiovascular disease, even before cardiovascular disease, what comes first is erectile dysfunction. Okay, so erectile dysfunction is what comes first. Okay.
Yep.
All right, thanks, Seun, for Leke. And I think while we're on the food, before I go to Oluyeye, there's a question in the forum, because you did mention about the type of oil to cook with. The question is, do you have any recommendation?
Olive. Olive oil. Olive oil is the best evidence that we have.
All right.
Yes.
Olive oil. Do you have a follow-up? Was that Bola that asked the question? Bola, did you have follow-up?
And I saw a question about, like, someone said.
Bola is speaking. We can't hear him.
Yeah, that's just the only question I have about the coconut, because I live alone here, and my family is in Nigeria, so I cook myself most of the time. So I just want to know which of the cooking oil, because right now what I use is sometimes I use vegetables, sometimes, So that's why I need to know which one is the best to use. But now I know.
Yeah, I think olive oil is the best, because that again brings me to what we call the oil products. So it's when you buy those oil, or maybe anything you want to eat, when you look at the fats at the back, okay. Try to, if it has a lot of trans fats, don't use it. Don't take it, okay. Trans fat is not good for you. Trans fat is what really causes the cardiovascular disease. So you will see, and they always put it there. So they will put the amount of trans fat, okay? Or you just take the trans fat that's very, very low. The next one is the saturated and unsaturated fat. So you will always see those two. You will see saturated fat, you will see trans fat. Saturated fat, you want to take. See, in a day, you don't want to eat more than 5 grams of saturated fat, okay? I think a cup of ice cream probably has maybe 8 grams of saturated fat. So what you want is what we call monounsaturated fat. It's unsaturated fat, unsaturated. So it could be monounsaturated, it could be polyunsaturated. If you look at the back of those things, they always write it there. So now we have to always be conscious of what you buy, okay? Even if it's oil, the type of oil that you're using, look at the back. If it's low in trans fat and saturated fat, I think you should be able to use it.
Yeah, thanks, Seun. Me alone, love my wife, because it taste it. Well, let me go to
unfortunately, I don't know. Maybe that's one thing I'm going to look for and get back to you guys. I don't know the components.
Because Owadoku is already sending message to the phone. So let me go to Oluyeye. Oluyeye, your question, please.
Yeah. Dr. Akinseye, I think I have to really appreciate you.
Thank you.
I feel so honored. To be part of this forum. God bless you.
Thanks.
Your knowledge and everything. This is gonna go a very long way for me as a person, because I've really learned a lot. And I thank God, because I actually wanted to take, to rest a bit, but I just felt when I saw the subject of the today's training, I felt it's gonna be very useful for me, which at the end of the day, I thank God for being part of it. But there's one particular thing that it's bothering me lately, and I think this is a very good forum for me to hear, some advice that you can give. Lately, have been having consistent back pain. I spoke with my PCP, and he gave me some medication which helped, and but I don't know if you have any advice, or probably I have to change some lifestyle. It bothers me a lot, because most of the time I feel, am I going to come out of this, and it subsides. So what advice can you give? Because when it comes, I'm always in pain. You understand? So.
Yeah. So which area of the back, low or lower back, or mid or high?
It's the lower one. It's the lower.
The lower back. Okay. The lower back. Yeah. So will this back pain worsen when you bending forward to do something, or maybe you are in that position bending forward for a while, and then you want to stand up? Does it worsen?
No, it's worsen when I'm up doing stuff.
I see.
Yeah.
And another thing I want to ask you is, but have you ever noticed maybe when you're climbing down the stairs, maybe it improves it or it makes it worse or better?
I can't say anything about that.
Okay, all right. So those questions are for me just to know maybe I'm dealing with something we call something sciatica, because the spine, usually your nerves comes from there. So from this spine, it does, from the way you're saying, is probably that's not what it is. There are cartilages in between those spines, right? And with age, your cartilages usually they kind of over time erode. So with time, which kind of everybody's going to have with time, but when the bones, when they start rubbing against each other, that's usually the beginning of back pain with some, and that's also beginning of what we call osteoarthritis. If the medication that your doctor gave you helped a little, I'm not sure what they gave, but that's always reassuring, okay? That's always kind of reassuring, because that means probably we're not dealing with any, because when anybody mentions back pain, which is a lot, the first thing you want to make sure is it nerve, is it spinal cord or stuff. So if it improves with some pain, that means probably it's just from the bones rubbing on each other, one, or it could be that the muscles around the backs are, just kind of tight and spasmic, okay? For me, what I probably would recommend for you is, number one, I don't really like medications for all these osteoarthritic pains, because I think medications that we use always have untold effects. I guess probably what they gave you would be ibuprofen. Is that what they gave?
Yeah, he gave me, he prescribed to me ibuprofen, and he gave me some muscle relaxer.
Yes. So in a while, you can, if the muscle relaxant help, maybe all you need, for me, usually if the muscle relaxant helps, maybe all you need is some physical therapy around there, some physical massage therapy and stuff.
Massage, okay. Full license, money.
Can you allow the doctor to talk?
Okay.
Oluchelu, can you please, Excellency, allow the doctor to talk?
So
right now, I've been a pastor for the past couple of days, because it's all about my life now.
Yeah. So especially if the muscle relaxant does help, then it's usually the spasmic muscles, or we call them the spasmic muscles around the spine, the paraspinal muscles. Usually that's what usually causes a problem. One way to do it is how can I say it? Because I want to give you a homemade. If you find something round, put it on the floor, something round, probably round that will kind of cover on that your back can cover on, and kind of roll on it, okay, with the back, and see probably how that helps. Again, the physical therapy guys might have a better advice on all these things, but I think maybe you might be dealing with a spasm issue.
Okay, thanks. Because I use something like this. I use something like this around whenever I'm in pain. You understand that? Plug it and do some massage.
Yeah. So I think probably that would be the way to go. If you can find help with therapy and stuff like that. But if it's not getting better, I will probably prefer that you get an X-ray first.
Okay, thank you. I'm appreciate it.
Sir, excuse me, I'm not asking a question, but based on my experience for the backache, I used to have backache before. When they give me medication, stuff like that. But I realized that my sleeping position when I sleep, right? Sleep tonight, the next day when I wake up, I feel some back pain. So I was trying to study my sleeping position. So when I sleep with my left side, when I wake up, I feel good. But when I sleep with my right hand side, right, by the night, I feel pains the next day. So each time I knew that, then I continued practicing that, sleeping by my left. Then since then, there was nothing like back pain anymore.